All right, let's jump right in. In this explainer, we're building a practical field guide to myocardial disease. We're going to break down three main ways the heart muscle can go wrong, and most importantly, how you can actually tell them apart when you're faced with a tough clinical case.
So, let's set the scene. You have a patient, they're short of breath, they're tired, classic heart failure symptoms. You get an echo, and sure enough, the heart muscle looks abnormal. This is a super common starting point, right? But the real question is, where do you go from here? The answer usually comes down to figuring out the root of the problem. Is the heart just too thick? Is it being infiltrated by something? Or is it simply too stiff?
First up, we're going to tackle the classic thick heart disease, hypertrophic cardiomyopathy, or HCM. When you see a really beefy-looking ventricle on an echo, this is probably the first thing that jumps into your mind. So what is HCM at its core? Well, it's genetic. It's a problem with the sarcomere, which is basically the tiny little engine inside every heart muscle cell that makes it contract. The absolute hallmark for diagnosis is a left ventricular wall that's 15 millimeters thick or more, and you can't blame it on something obvious like years of high blood pressure. And get this, the prevalence is about 1 in 500. I mean, think about that. This isn't some super rare textbook-only disease. It's actually incredibly common, which is exactly why you have to have it on your radar.
For a lot of patients who have symptoms, the whole problem can be boiled down to this really elegant triad: eject, abstract, leak. So as the heart squeezes to eject blood, the mitral valve gets pulled forward, right into the path of the blood trying to get out. That's your obstruction. And because the valve is pulled out of place, it can't close properly, which causes a leak, what we call mitral regurgitation.
And here's the really cool part. This pathophysiology leads to a diagnosis you can start to make right at the bedside. The murmur in HCM is dynamic, so anything that decreases the amount of blood in the ventricle, like standing up quickly or having the patient bear down, makes the chamber smaller, the obstruction worse, and the murmur louder. But if you have them squat, more blood returns to the heart, the chamber gets bigger, the obstruction gets better, and the murmur gets softer. It's beautiful. Of course, to really nail the diagnosis, you've got to get that Doppler echo. And we're not just looking, we're measuring. We're trying to find a specific number, a pressure gradient across that outflow tract of 50 millimeters of mercury or more. That number is the magic threshold that tells us the obstruction is severe, and it's time to start thinking about more invasive treatments like surgery.
Now, when it comes to managing symptoms, your first-line drugs are non-vasodilating beta blockers. But honestly, what you avoid is just as critical. Things like nitrates are a big no-no. Why? Because they decrease preload, making that obstruction even worse. Same thing with digoxin. You really have to be careful and precise with your pharmacology here. Okay, let's totally shift gears. We've just talked about a heart that's too thick because the muscle itself has overgrown. Now, we're going to look at a heart that's thick because it's been infiltrated by something that shouldn't be there. Welcome to cardiac amyloidosis. Now, it is absolutely critical to know what kind of amyloid you're dealing with. Is it AL amyloid, which comes from a plasma cell problem, or is it ATTR amyloid, which comes from a misfolded protein called transthyretin? And this isn't just academic, because the treatments are completely different. One requires a hematologic approach, while the other uses new drugs that stabilize that misfolded protein.
Okay, if you remember one single thing about cardiac amyloid, let it be this. This is the classic pathognomonic clue. You look at the echocardiogram and you see these massively thick ventricular walls. But then you look at the ECG and you see low voltage. This mismatch, this paradox of a structurally huge but electrically quiet heart, that should scream amyloid.
And that brings us to our third and final category, the stiff heart. This is restrictive cardiomyopathy, or RCM. And with RCM, the fundamental problem isn't thickness or infiltration, it's just a profound lack of flexibility. Now, pay attention to the key differences here. The ventricles are so stiff they can't relax and fill properly. That's severe diastolic dysfunction. All that pressure backs up and causes the atria to become absolutely massive. But, and this is what can throw you off, the ventricular walls themselves are often normal thickness, and the squeeze, the systolic function, is usually fine. Okay, here's maybe the biggest diagnostic challenge in this whole talk. You have to be able to tell RCM apart from constrictive pericarditis. They can look almost identical clinically, but getting it right is life-changing for the patient. Why? Because while we have limited treatments for RCM, constrictive pericarditis can often be flat-out cured with a surgery to remove that stiff outer sac of the heart.
So how in the world do we tell them apart? Well, a few key clues. Remember, in RCM, the problem is the muscle itself,
In constriction, it's the sac around the muscle. A simple blood test, BNP, is usually sky high in RCM, but pretty low in constriction. And the absolute physiologic hallmark of constriction is something called ventricular interdependence, where the two ventricles are getting squeezed so tightly that when one fills, it pushes on the other. You just don't see that in RCM.
Okay, we have covered a ton of ground. So now let's pull it all back together. We're going to put all three of these conditions side by side to really lock in those key differences.
This is really the money slide. Let's break it down. HCM, think thick and obstructed muscle, asymmetric hypertrophy on echo, and high voltage on the ECG. Amyloidosis, think infiltrated and stiff, symmetric hypertrophy, but with that classic low voltage ECG clue. And finally, RCM, think stiff and non-compliant, with the unique feature of normal wall thickness, but those giant atria and really severe diastolic problems.
So we'll end with a thought for the future. For so long, we defined these diseases by what they looked like. But now we're entering this incredible new era of molecular diagnosis and targeted therapy, from widespread genetic testing for HCM to protein stabilizers for amyloidosis. So the big question isn't just what we know now, but how is this deeper understanding going to completely reshape our field guide in the years to come?